although you're still muted, Simona. Great.
All righty, can everyone see? Awesome.
Can't hear you.
Okay. All right. Hi, everyone. I'm Simona once again. I'm one of the fellows here at East Tennessee State University. Today, I will be talking about drug testing. So the title of my presentation is Appropriate Use of Our Tools, Drug Testing. I have nothing to disclose for this presentation. Learning objectives. So by the end of this presentation, people who view this will be able to identify various types of drug testing available, differentiate between qualitative versus quantitative urine drug testing, evaluation of a urine sample, and develop an understanding of the purpose of urine drug screening in the treatment of patients with substance use disorders. So what are the principles of drug testing in addiction medicine? So whenever we do any kind of drug testing, it's recommended as a therapeutic tool as part of evidence-based addiction treatment. We use it to explore our patients' motivation, also denial when we're treating them. It's an important supplement to self-reporting. And it's a method of providing motivation and reinforcement for abstinence. In terms of the different principles of drug testing, so evidence suggests that drug testing can improve patient outcomes. We need to educate our patients that when we do perform these tests, they're not punishment. It's not meant to be punitive, and it's meant to be therapeutic. We need to combine these along with a patient history, psychosocial assessment, and a physical examination. It also may be used to help determine level of care. And we should always interpret these test results in the context of what our patients reporting to us. So whatever we obtain from getting a history, other indicators, and also in the context of collateral information. So what can drug testing do versus can't do? Drug testing can measure if a particular substance has been used within a particular window of time. It can be used as a therapeutic tool. It can monitor recent substance use, the effectiveness of a patient's treatment plan, and it can be used to guide treatment plans. Now this is important. So what can drug testing not do? So it cannot diagnose a substance use disorder. It cannot rule out substance use disorder. It cannot identify every potential substance that a patient's using, or it cannot prove that substance use has not occurred. So what types of drug testing is available? So we can perform drug testing on urine, hair, saliva, sweat, and meconium. Some things to consider include window of detection, time to obtain results, how easy is it to collect, invasiveness, and susceptibility to tampering. And I'll talk about that more in this slide in a second. So this slide is, quite busy. What I wanted to show was to kind of compare and contrast between, blood testing versus breath, oral fluid, urine, sweat, and hair. So as we can see, for blood testing, is usually used best in patients who are acutely impaired. General detection period is between 1 to 48 hours. It primarily detects parent drug screen, blood alcohol concentration. On-site testing is available for alcohol. It does require training. It is pretty intrusive and it's resistant to tampering. It's pretty difficult to retain and retest a sample. In terms of breath testing, it's best used once again in acute impairment, generally about an hour per standard drink. It primarily detects parent drug. On-site testing, it can be available for alcohol. It's pretty easy to collect. It doesn't really take much. It's not very intrusive. And it's pretty resistant to tampering. generally not possible to retain and retest a sample. In terms of oral fluid, it's best used for short-term detection. It can detect anywhere from 1 to 48 hours. It detects parent drug. On-site testing is available, and it's pretty easy to collect, low intrusiveness, and pretty highly resistant to tampering. And it's actually difficult to retain and retest a sample, but just kind of walking down to the rest of them. So we can see with urine, there is a high, actually it is pretty, it's mostly tampered with. A lot of our patients find it very easy to tamper the urine. On-site testing is usually available. And it's pretty, it's possible to retain and retest a sample if needed. Usually with hair samples that can detect, substances for up to 100 days. It primarily detects parent drug. It's easy to collect, low intrusiveness. There's high resistance to tampering. It's easy to retain and retest a sample. So sorry, it's a busy slide, but I just wanted to kind of compare and contrast these different testing methods available. So urine drug testing is actually the most common testing that we use. It's non-invasive. It's pretty easy to collect. It has a low cost associated with it, and it's available in most office settings. And usually we can detect, drug detection times are longer in urine compared to blood. It is most prone to tampering. There are two main types, the screening and confirmatory. So first, I'd like to talk about the tests that we use for screening. So that would be immunoassays. So immunoassays is the initial screen. It's presumptive, it's qualitative, it provides rapid results, often at the expense of accuracy. It's sensitive but not specific. There are three main types available. So enzyme multiplied immunoassay technique, the ELISA testing, and fluorescence polarization immunoassay. So this technology uses antibodies to detect drug metabolites or classes of drug metabolites, and it can often lead to cross-reactivities. So there's a high likelihood of false positives. As I had mentioned, it's often at the expense of accuracy. It can also lead to false negative results if the value is below cutoff. So it's important for us to know, any test that we use, what are the cutoff values for that specific test. Next, we have GCMS versus LCMS, so also known as gas or liquid chromatography, mass spectrometry. We use this for confirmatory testing. So it's definitive, quantitative, it can identify specific molecular structures, it's highly specific, it quantifies the amount of drug or substance being used. It must be conducted by highly trained personnel. It's pretty time consuming, it's costly, and we should always conduct, always send for confirmation when making any legal, forensic, academic, employment, or other decisions that have significant consequences, especially since I said earlier, initial testing there's a high chance of false positivity as well. Now, if you have a patient in clinic, let's say their urine, their initial test was negative, but they're showing signs of relapse, you can definitely send a confirmation to kind of find out what's going on. Cutoff levels. So I briefly mentioned this before. So cutoff levels basically define the concentrations needed to produce positive results for immunoassays and confirmation testing. They help minimize false positive results. For example, if an individual consumes, let's say they eat multiple bagels with tons of poppy seeds on them, they could test positive for opioids technically, or, if there's passive inhalation of marijuana. So that's why these cutoff levels were designed. Results lower than the established cutoff level are going to be reported as negative. So negative results mean the concentration was lower than the cutoff value. And usually with federal cutoff values for the workplace were developed by the Department of Health and Human Services. Higher cutoff values may be necessary to avoid false positive results, as I had mentioned about the poppy seeds. However, in medical practice, lower cutoff values may be necessary to avoid false negative results. Detection times is something else that we should definitely also know about when evaluating drug testing. So we have to take into consideration amount, so the amount of time drug can be detected in the urine and produce a positive result. We need to keep in mind drug characteristics, so half-life, drug metabolites, drug interactions, dosing intervals, the amount of dosage, low versus high, chronic versus occasional use, and the last time of ingestion. And we should also take into consideration patient factors. So body mass, urine pH, urine concentration, renal or liver impairment. So the next couple of slides, I'm going to talk about approximate drug testing, drug detection time in the urine specifically. So in terms of alcohol, the length of time that it can be detected is 7 to 12 hours. Amphetamine, 48 hours. Methamphetamine can be 48 hours as well. Barbiturates, depending on whether it's short acting or long acting, it can be anywhere from 24 hours to 3 weeks. Benzodiazepines, so Valium or diazepam is our longer acting. Benzo, that can be detected up to a month. Cocaine is usually 2 to 4 days. Marijuana, and as I had mentioned before, it depends on how much, on how often a patient's using. So if they are a chronic heavy smoker, they will test positive for at least a month. Opioids, depending on the type of opioids, it can be anywhere from 2 to 4 days. And then we also have phencyclidine, which can be up to 8 days, and synthetic cannabinoids, depending on how often they're using. This table actually shows us the different medications that can result in false positive results on urine drug testing. I got this from the American Academy of Family Physicians. It was an article that was released. So pretty much from amphetamine, so as we can see, multiple substances can result in false positives. So it's very important for us to review, our patient's medications list and see like what else they're prescribed, or even ask them what else they're taking if it's not prescribed. So to name a few, so we have amantadine, we have bupropion, a lot of the stimulant medications, so Ritalin, Adderall, phentermine, which we use for weight loss. So a lot of these, trazodone, that's a really common one that we prescribe for sleep. So a lot of these can cause false positives for amphetamines. Benzodiazepines, Zoloft, sertraline, so SSRIs. For cannabinoids, dronabinol, which is Marinol, efavirenz, proton pump inhibitors, NSAIDs can also cause it. For cocaine actually rarely causes false positives, but if a patient, it could be like a topical anesthetic containing cocaine, that could possibly lead to a positive drug screen. Opioids, we have dextromethorphan, heroin, rifampin, verapamil, and phencyclidine can be dextromethorphan, Benadryl, doxylamine, ibuprofen, ketamine. So it's always good to know these so that we can, identify what are some, especially when we discuss these results with our patients and they say they're not, they haven't used any amphetamines, like what else could be causing this, especially with that initial screen. I wanted to put this slide on here to talk about metabolism of opioids, because it is important to know the pathway, and especially when we're looking at a confirmatory screening, because that's more specific and will show us molecular, the different structures. So for heroin metabolizes into 6-monoacetylmorphine, that's also known as 6-MAM, and that metabolizes into morphine. Codeine metabolizes into morphine, and it also metabolizes into hydrocodone, which then goes into hydromorphone, oxycodone becomes oxymorphone. It's important to know this because if you do see 6-MAM, if a patient tests positive for that, we know that's specific to heroin because it is a metabolite of heroin. So knowing these pathways will help us identify what substances our patient has been using, especially when they're not, if they do not self-report. And this slide over here shows benzodiazepine metabolism. So, your patient might say, doc, I'm only taking Klonopin, but if they test positive for nordiazepam or oxazepam, we know that's not a metabolite of Klonopin. Usually those are metabolites of Valium, so diazepam. So it's important to know these, and I put these on there for that purpose. So let's talk about evaluation of a urine sample. So pretty much, I'm going to, so when you look at a normal urine, it's supposed to be pale yellow to clear. Morning collections have highest, concentration, so will contain higher levels of the drug. We should look at the temperature of the urine, and we must record this, usually within the first 4 minutes after collection. Usually temperature ranges between 90 degrees to 300 degrees with a volume of 30 cc's or more. Usually the pH of normal urine ranges between 4.5 to 8. The other thing we look at is specific gravity, and it's important to note it ranges between 1.002 and 1.030. Creatinine can vary depending on our patient's hydration status. In normal urine, it should be greater than 20 milligrams per deciliter. So how can we tell if our patient has tampered or altered their urine, which is very common. It's most prone to tampering. So if the pH is less than 3 or greater than 11, if the specific gravity is less than 1.002 or greater than 1.030, and actually a creatinine less than 5 in combination with a very low specific gravity less than 1.001, it's not even consistent with human urine. And sometimes patients do that. They'll put another substance in and not give us a human urine sample. And usually if urine creatinine concentrations are less than 20, that's indicative of a dilute urine. So how do we respond to these unexpected results? So we should use these unexpected results as a differential. We should always speak with our patient, discuss it with them, what our findings were. Once again, drug testing should be used as a therapeutic tool. It's something that we do for our patients and not to them. We should engage in a therapeutic and non-confrontational discussion. We should review all medication, and also when we're looking at buprenorphine, how are they taking it? Are they snorting their medication? Are they taking it under their tongue? We should seek definitive testing if our patients deny substance use. So confirm it, send out a confirmation. We should consider higher levels of care or adding adjunctive treatments if a patient, for example, if they do test positive for methamphetamines, what can we do differently? How do we address this? Frequency of testing. So per the SAMHSA, per their tip 63, it says to test as frequently as is necessary to document a patient is adhering to mutually agreed upon treatment plan. Initially, when they're first presenting to treatment, you want to perform drug testing at least weekly, at least monthly for patients who are stable. And if possible, you can also do that in a random interval schedule and not a fixed interval schedule, because sometimes patients will time themselves, for example, with methamphetamine, they know it's positive for 2 to 3 days, and they may not use right 3 days before their test. So this was an interesting article that I found on PubMed. It was recently written, following the COVID-19 pandemic. As we all know, it's forced us to change our practice. Federal regulators have relaxed guidelines requiring in-person evaluation for the initiation of buprenorphine for opioid use disorder in the context of OBOTs. And they pose an interesting question. Is it time to put an end to routine urine drug testing? So I'm just gonna, put that out there, and, maybe it can generate a good discussion amongst us to see what everyone else thinks. The article talked about how there is evidence that, that we don't absolutely have to do urine drug screens to help our patients, that we can make it patient-centered and base it on self-reporting. All right, so this leads me to the conclusion slide for my presentation. So just to kind of go over a few more things. So we should use drug testing as a routine part of initial and ongoing assessment of recent substance use in all addiction treatment settings. We should use testing in conjunction with what our patient is self-reporting, what their treatment history says, psychosocial assessment, and a physical examination. We must include these in intake and also with ongoing assessment. We must individualize based on a patient's drug of choice, prescribed medications, and drugs commonly used in the patient's geographic location. So there are different types of testing available. Our testing actually, our point of care urine drug test does not show, it doesn't pick up fentanyl, for example. And actually, the other thing to mention really briefly is also if a patient is taking Klonopin, our test does not show that. We should also use drug testing to ensure adherence with prescribed medications and monitor for possible diversion. But once again, take into consideration what our patients are telling us and not dismissing them just based on their drug test alone. So always sending out for confirmations and clarifying what we're seeing. So treating our patients and not the drug test. And we should base our frequency of testing based on the patient acuity and level of care. Here are my references. That being said, this concludes my presentation. Does anyone have any questions or comments?
Thank you so much, Simona, for your presentation. So if there are questions or comments while we are letting Skylar get his, because I saw him working on it earlier today, his patient case loaded, this is a good time to do that. It was a lovely presentation, Simona. Thank you, because it's one of those things like, oh, you run the thing and you get some results, and then that's what they are, right? Maybe not. So that was a good run over of why it may not be what you think you got and the importance of backing that up and working with your patient.
Thank you.
You're welcome.
Thank you for the presentation. I was just curious, how common is it for like medications like sertraline or trazodone or some medications to show up as a false positive? Is it like 90% likely, 10% likely? Has anyone ever actually seen this in real life? I'm just curious.
That's actually a really good question. Unfortunately, I don't know exactly like what's the likelihood, like what the percentage is. But I will say I do have a patient right now who actually she's not even on Zoloft. She's on high dose Prozac, and she's actually tested positive for benzos on her initial testing multiple times. And the first couple of times, I did send it for confirmation, and the confirmation would always say that she was negative, negative for benzos. So I think it's because of that high dose Prozac itself. So yeah, I have seen it. I've also seen a patient who was positive for amphetamines, while on trazodone at the VA. I wouldn't say it's very, very common, but it is possible.
I know the cups that we use, the point of care testing, they say about 10% of the time there's a potential for false positive, false negative, that sort of thing. And years ago, one of our nurse practitioners who was taking Zantac daily took one of our tests and tested positive for methamphetamine. So it does happen.
It's always a dicey thing when you use yourself or your employees for your control on your test cups. Is that the Zantac?
According to her report, it was not methamphetamine.
No, good. Amanda actually posted in the in our chat just that she was unable to introduce earlier. She is also a family nurse practitioner resident at ETSU in the substance use and psychiatry program. So thank you for joining us, Amanda. And then, as always, wonderful Rick has posted a number of citations for us. You've got the references from Simona's presentation, but then Rick has also put up some other additional reading. So if you haven't copied your link for the survey yet, you can go in and grab that while you are grabbing the names and citation information for the articles that Rick has shared with us as well. Thank you, Rick. Skylar, are you ready to share your case with us?
I want to mention something about the question that was just in my practice. I always consider the positive for something that shouldn't be in patient's urine in a discussion with the patient. And I would approach the patient this way that, okay, urine drug screen came back positive for the benzodiazepine, and benzodiazepine are these medications that, for example, lorazepam, diazepam, and so on. And are you by any chance been taking any of this medication? Even if they have a Zoloft, for example, on board, I would not assume that this is a false positive. I would always discuss that one with the patient. But I have seen plenty of the time that it was false positive with the confirmation, as Simona says.
Perfect, thank you. Hydralazine is one I had for a patient who had blood pressure issues during her pregnancy, and it was the only thing we could get to control it. She was continuously positive for methamphetamines, which was just strange, but true. They both have a nitrile ring, very similar chemical structure. So I think that's why we were getting that false positive for her, which every single one of her confirmatories was negative. So yeah, you do see it. So being aware of that is incredibly important, and having those good conversations